Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Walker, Chair of the Department of Medicine. Today is a special Grand Rounds. It's the Cardos Renal Grand Rounds. And before we introduce our speaker, I'm going to have Chi Shu, the Chief of our Division of Nephrology at UCSF Health, talk a little bit about Gary Cardos.
Thank you, Bob, and welcome. Deidre, I know some members of the Cardos family, I hope are online, and we want to thank them for their support of this program. This is our annual in-person visiting professor, which we've resumed after COVID. Gary Cardos was a medical student at UCSF and then did all his medical training here, including being a chief resident. He subsequently practiced nephrology at the first public dialysis unit west of the Mississippi at San Francisco General Hospital, and then the first dialysis unit in private practice at what is then became CPMC Davis. He was in practice for many years and then returned to UCSF to serve on the faculty. I think he was notable for being a person who kept up his passion for clinical medicine despite being in practice for so many years, and always stayed on top of academic articles, and really his patients loved him, and he made a deep impression on many trainees who spent time with him while he was here. And I would particularly want to note that he's also a cook, actually, and I think will be very in favor of today's Grand Round topic related to food and kidney disease. I think partly will be what Dr. Cruz will be talking about. So.
And here we have a picture of Gary. Today we're doing hybrid. We have a small but mighty crew here in 217, and far more people virtual. Next week we'll be going back to virtual, and for at least the next few months we're mostly virtual. We'll do a few hybrids, largely when we have visiting professors, and we're thrilled that we have one, an exceptional one right now. So. Our speaker today is Dr. Deirdre Cruz, who's professor of medicine in the Division of Nephrology at Johns Hopkins, also affiliated with many other entities at Johns Hopkins, including the School of Public Health, School of Nursing, the Welsh Center, and others. She's also deputy director of the Center for Health Equity at Hopkins. She was an undergraduate at Virginia, got her medical degree from St. Louis University, then came to Hopkins and did not leave as a resident, nephrology fellow, master's in clinical epidemiology. One of her key mentors there was Neil Poe, who we were lucky enough to recruit to UCSF several years ago. If I named all of Deirdre's honors, I would take her entire time, so I won't do that, but I will say that she's a elected member of the ASCI. She won the Johns Hopkins University President's Frontier Award. She was part of the National Academy of Medicine Emerging Leaders Program. She's a master of the American College of Physicians, and she's won a Distinguished Leader Award from the American Society of Nephrology. And as either reward for that or penalty, she is the ASN's president-elect. So she'll become the president of the Maine National Society for the field of nephrology next year. So she's had an incredibly impactful career, lots of really influential research, as well as her work as a clinician and educator. Her work has largely focused on elucidating the root causes of disproportionate burdens of kidney disease on marginalized populations and the role of social and behavioral determinants of care on kidney disease. Incredibly important work, one that, of course, has gotten much more visibility in the last several years. So we are thrilled that she's been visiting professor for the last couple of days, has had a chance to visit the county, the VA, Parnassus, really gotten to see the whole place, including this bizarre weather. So thank you for tolerating all of that, and I've got wonderful feedback from your visit. Look forward to hearing you talk today, which is entitled Centering the Margins to Achieve Kidney Health Equity. Welcome.
So thank you so much. I really appreciate that warm introduction. And I've deeply enjoyed my visit here, and consider it quite a privilege to want to thank the Cardos family for supporting this visiting professorship, and certainly in particular thank my colleagues in the Division of Nephrology here who've been such wonderful hosts during my time here. So I'm going to be speaking with you all on this topic that you heard about a moment ago. So centering the margins to achieve kidney health equity. These are my disclosures, but I won't be discussing any of the commercial products of any of these companies during our time together. So first, some objectives. First, what we'll do is to try to together understand this concept of centering the margins as a framework for advancing health equity. We'll go on to recognize the profound disparities in chronic kidney disease and some of the societal impacts of those disparities. And then we'll discuss some of the potential root causes of disparities in CKD and some opportunities to mitigate these disparities. So first, centering the margins. This concept of centering the margins actually emerges from the seminal work of Bell Hooks, who was most well known for work at the intersection of race, gender, sexual identity, and class, and whose book, Feminist Theory from Margin to Center, led to what is now known as a center margin theory. And this sort of simple depiction of the essential aspects of this theory really highlight that for those individuals who are at the center of a society, this refers to their automatically being accepted into society due to their race, their ethnicity, their socioeconomic status, their sexual identity, or really anything else that in a society grants access without effort. And so for these individuals, again, no effort is required to remain at the center or to remain as the focus of that society. Whereas those who are considered at the margins of society, these are going to be individuals who are not automatically included at the center because of those same factors. And they actually themselves either have to exert effort to be placed at the center or have others exert efforts on their behalf. So when we think particularly about the context of health and public health interventions, it's very key that we consider bringing those who have been systematically placed in the margins of society into the forefront of our efforts. And certainly in the setting of the pandemic, we've seen how important this is in particular, but certainly it is the case for other fields, even outside of certainly of infectious diseases. So when we look at kidney disease, what we see is that the impact of kidney disease on socially marginalized populations has really been profound. We know that Black, Hispanic, and Native American people have higher rates of kidney failure than non-Hispanic white people. We know that racial or ethnic disparities in kidney health are not fully explained by genetic risk variants. Many of you may be familiar with the genetic risk variant of apolipoprotein L1, which is prevalent in around 12 to 13% of people who would self-identify as having African ancestry, sort of including Black Americans. But we know that even when we consider and compare, for example, Black Americans who have the lower risk genetic variants for ApoL1 to white individuals, we still see tremendous disparities in outcomes when it comes to kidney disease. Again, really underscoring that that these racial and ethnic disparities are actually not fully explained by these genetic factors. We know as well that people with lower incomes have higher rates of chronic kidney disease. And important to our field is this issue of awareness, or this limited awareness of chronic kidney disease, in that it's been estimated that around 9 in 10 people who have chronic kidney disease are actually not aware that they have it. And awareness is actually lowest among several high-risk groups. And some of that work has been done to help us understand this, has been done by colleagues here, including Dr. Chi Chu and Dr. Delphine Tuo, on helping us sort of understand this issue of awareness. So when we look at the last sort of few decades with respect to these disparities and these inequities in chronic kidney disease, what we see is that these gaps in CKD prevalence have really persisted across around the last 3 decades or so. Here in particular, thinking about those gaps around when we compare racial and ethnic groups, as well as comparing people of different socioeconomic sort of levels. I think we're okay. Yeah, it was verifying OneDrive. So importantly, what we've seen is that in this study, one of the things we found was that CKD prevalence has almost doubled among Mexican American individuals over the last when we compare the earlier time period around nearly now 3 decades ago to a more recent time period. And we know that other racial and ethnic and socioeconomic groups haven't experienced appreciable increases in their prevalence of CKD, but that these gaps between these groups has persisted during this time. So I'm certain that we can all agree here that health disparities are inhumane. As it turns out, they are also tremendously costly. It's been estimated that around $1.2 trillion are spent each year in the United States due to the combined cost of health disparities and the subsequent deaths that occur among racial and ethnic minoritized individuals due to their inadequate or inequitable care that they receive. It's also documented that around 30% of the medical expenses for racial and ethnic minoritized people are actually excess costs that stem from health disparities. And importantly, to think about how we compare to other countries around the world, one of the things that many scholars would argue that sort of sets us apart or in some ways sets us back compared to some of our economic peer nations around the world is that we actually spend less on social services than do our economic peer countries. And we are, in fact, the only country that spends more on health care services than we do on social services as a percentage of our gross domestic product. And again, many would argue that this is why we don't enjoy the same health benefits that we might expect given our sort of overall economic status. And so a number of different conceptual models have been put forward to help us think about the factors that are at play when we consider why different socially marginalized populations are at increased risk of developing kidney disease and also seeing it progress to kidney failure and even premature mortality. This is one that I like and that I use often and reference often, because I think it captures sort of 3 major areas that are important drivers or root causes of these disparities. So if I could draw your attention to the far right-hand side of this figure, what you'll see is those factors that stem from uninsurance status or underinsurance status. And of course, for those individuals, that's going to mean that they may have limited access to healthcare. They may have then delayed or even not at all detection of their CKD risk factors and control of or sort of treatment for CKD. And then certainly they can go on to develop chronic kidney disease and also see it progress. In the center of this figure are those issues that stem from the experience of discrimination. So including both sort of psychological or psychosocial factors like chronic stress and what it can do biologically to people, including the effect that it has on our neurohormonal activation. It can also influence people's behaviors. Their sort of substance use, for example, their physical activity, overeating, for example, is also influenced by these experiences, and that, of course, can then lead to ultimately them having greater risk of developing kidney disease. And then on the far left-hand side are those factors that stem from residential segregation, and here really highlighting things like poor educational systems, poor housing, exposure to environmental toxins. We think about things like lead and other heavy metal exposures, which we know are risk factors for kidney disease. And people who live in these residentially segregated areas may have greater exposure to these factors. And then again, they can go on to have to develop these more clinical risk factors for kidney disease and ultimately CKD itself. During our time together today, I want to highlight for you some work that my colleagues and I have done, including many colleagues here at UC San Francisco, on some of these areas, as well as I'll draw from some work of others, really to sort of highlight these key areas. I think important to note that where we are today, and as Dr. Wachner or Bob, as he's asked me to call him since I'm on the West Coast, has shared, we know that over the last couple of years, there's been an increased sort of focus on health inequities, and really now I think most scholars would say that a lot of what I shared in the previous slide and sort of thinking about these determinants of inequities in kidney disease, most would argue that the sort of overarching force is structural inequity, or in specifically structural racism. And here referring to the many ways in which a society fosters racial discrimination through inequitable allocation of resources and opportunities embedded within mutually reinforcing systems. So things such as housing, access to care, access to healthy foods, what is often these factors often being referred to as social determinants of health. It's now increasingly recognized that these structural inequities are the major cause of the race-based health inequities that we observe. And institutions such as the NIDDK, or the National Institute for Diabetes, Digestive, and Kidney Disease, have actually called together really people to focus on this issue in kidney disease. And there's been work like this being done elsewhere within the NIH in particular, such that at NIDDK, we held a workshop earlier last year, and then ultimately a request for applications for interventions addressing the impact of structural racism on kidney health was sort of put forward. And so there's definitely greater attention to this issue. And so really kind of highlighting, again, going back to that conceptual model, these areas that are, I think, key underpinnings of the disparities we see in kidney disease. I want to sort of first touch on this issue of access to high quality, equitable healthcare. And I need not, I'm sure, tell this audience that over the last couple years, the very way that we diagnose kidney disease has undergone a revision or a sort of reassessment. I was honored to be a part of this committee that was led by two UCSF faculty, Dr. Delgado and Dr. Poe, which was a joint task force between the National Kidney Foundation and the American Society of Nephrology, really to reassess the practice of the inclusion of race in our estimated glomerular filtration rate reporting, and ultimately recommend an equation that does not include race, an equation that was refit without the race variable. And I'll say that one of the hopes from this is that this could, we hope, lead to a change in terms of the timeliness of detection of kidney disease among Black individuals, because that's who was the only group really affected by this previous equation that we were using. So GFR, as you probably know, is very central to the work that we do in nephrology. And in this study by Dr. Chi Chu here at UCSF, one of the things that we were looking at was when we think about referral to transplantation. It's something that right now is very it's based upon a certain cut point of an estimated GFR of 20 or less than 20. And one of the key concerns is that because of a number of disparities in terms of even referral to see a nephrologist and also timely referral for transplant evaluation, that certain minoritized groups are at a distinct disadvantage when it comes to being able to get a kidney transplant prior to having a need for dialysis in the case of kidney failure. And so in this study really highlighting that that the sort of progression even beyond or having an estimated GFR less than 20, that for Black and Hispanic individuals, their sort of risk of kidney failure is still going to be quite high, and they progress at a faster rate in terms of loss of eGFR kind of after that point of an estimated GFR of 20, really kind of placing them at a disadvantage when we use these specific cut points for referral for transplantation, or for listing for transplantation, I should say, and really calling for, I think in this study, we were sort of calling for a look at like who's at risk of rapid progression as opposed to just using this particular threshold. But as I touched on, a key issue is that there are significant racial and ethnic disparities in even who is seen by someone like me or my colleagues in nephrology prior to developing a need for treatment of kidney failure, either in the form of dialysis or transplantation. In this study led by my colleague at Hopkins, Dr. Tangela Purnell, what we found by using sort of national data was that Black, Hispanic, and Asian patients were less likely to receive nephrology care within 12 months of initiating dialysis. And so I'll highlight for you in particular that Hispanic individuals, even in the most recent time period that we examined in this study, they were 39% less likely to be seen in those 12 months prior to needing to start dialysis. And so if you're, thinking, well, what do we do during those 12 months? This is a period where we can even diagnose the cause of the kidney disease in these individuals, and we can, as indicated, start them on specific treatments for their type of kidney disease. There's immense disparities in who, for example, gets kidney biopsies in part, I'm certain, as a consequence of a lack of timely referral to see a nephrologist. And so this becomes a great issue. Now, for those who have been following along and heard me mention uninsurance status and underinsurance status as a key driver of health inequities with respect to kidney disease, you're probably wondering, well, are these disparities that we see in timely referral to nephrology a consequence of disparities in insurance coverage? And for sure, in this same study, when we adjusted or accounted for insurance coverage, we did find that these disparities persisted, but were attenuated, particularly among Asian individuals, where in the most recent time period, there then was sort of equivalent rates of nephrology referral. But this finding did still persist for Hispanic people in particular, where they were still 10% less likely to be seen by a nephrologist in the year prior to developing kidney failure. So for those, I had the great pleasure of visiting the VA here yesterday. As you heard, I got to see all three campuses, which was nice. And so for those that work at the VA that may perhaps be tuned in, that is a setting where the patients have they have the same really coverage. And so this study by Dr. Suarez and colleagues looked at whether there was a difference in outcomes as far as progression to among individuals who had stage 4 chronic kidney disease, whether there were racial and ethnic disparities in progression to stage 5 CKD in the setting of a system where everyone has, in theory, equal access to nephrology referral. Importantly here, they found, if I could draw your attention, I hope my mouse works, but what they found was that Black and Hispanic patients were actually more likely to be referred to see a nephrologist in this VA system, which many would argue is probably appropriate because these are going to be populations at greater risk of progression, and maybe had been sort of moving faster in terms of declines in their kidney function. But when they then looked at progression from stage 4 to stage 5 CKD, they continued to see these disparities where Black and Hispanic individuals were more likely than non-Hispanic white veterans to progress to stage 5. So really arguing that there are other factors that are at play besides the provision of health care or nephrology care specifically in this setting. And so turning to discrimination, which is an area that has been understudied in kidney disease, but my colleagues and I have done some work in this space that I'll share with you, as well as some colleagues who have done some work in the Jackson Heart Study on this topic. So we were interested in looking at this issue of perceived discrimination and change in kidney function, and we used data from a Baltimore-based cohort study called the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, or quite a mouthful, but it's the HANDLES study for short. And the HANDLES study was designed in such a way that roughly half of the participants are Black American and roughly half are white Americans, and roughly half have lower socioeconomic status and roughly half have higher socioeconomic status. So really designed in such a way to facilitate teasing apart both racial and socioeconomic disparities in health. And in this case, we were interested in looking at self-reported perceived racial and perceived gender discrimination across 5 distinct situations. So these included in the setting of being at school or sort of seeking an education, in the setting of seeking employment, in the setting of already being sort of in your job, in the home setting as well, and also in the setting of seeking medical care. And we also examined this general measure of the experience of discrimination that's been examined in a number of different cohort studies in particular. And what we found, I'll provide you just with a brief summary here, was that among white women, we found that the experience, a high level of experience of discrimination was associated with a lower baseline level of kidney function or lower estimated GFR at baseline in this study. And we also found that among African American women, both perceived racial and gender discrimination were linked to a lower follow-up level of kidney function. So when we followed this cohort for around 5 years, we found that those women had a sort of a greater risk of having this lower level of kidney function if they had experienced both racial and gender discrimination. So how does this kind of show up in the healthcare setting? This study by Dr. Diamantidis and colleagues used data from the Jackson Heart Study, and many of you may be familiar with it. It is focused on heart disease, as it may sound, and based in the Mississippi Delta area, so Jackson, Mississippi. And it's a cohort of African American individuals. And here they looked at around 3,200 participants who had either CKD, diabetes, or hypertension. And they examined various factors, sociodemographic factors, as well as psychosocial factors, and whether they were associated with the sort of practice of seeking routine medical care in this cross-sectional study. And what they found was that those individuals that had a low level of trust in their healthcare providers, or had a sort of high experience of stress or a high level of experience of daily discrimination, that each of those were associated with being sort of less likely to pursue and complete routine medical care, which of course we see as being very important for sort of certainly maintaining a person's health status. And so that was again, one of the few looks at discrimination and kidney outcomes. So turning to residential segregation, which is where we'll spend a good portion of our time today. So we know that residential segregation is really among the most potent forms of structural racism via practices such as redlining, which many of you are likely familiar with, but was the practice that began about 100 years ago, 90 to 100 years ago, whereby banks would restrict their lending to communities that were predominantly, where the residents of those communities were predominantly from particular minoritized populations, specifically Black individuals in most of these cities, as well as they would restrict lending to areas where the residents were predominantly from religious minority groups, including Jewish individuals. I am visiting with you all from Baltimore today, and I'll share with you. So on the far right-hand side is the redlining map of Baltimore from the 1930s, and so you'll see that the community that is shaded in red was the community that was redlined and considered a hazardous place for banks to provide loans. Whereas those that are shaded in green were considered the best or the optimal places for lending. And this is, so just to place a box around this is the redlined community. You'll see the redlining map for San Francisco, again, around the same time period. Baltimore at the time was one of the earliest cities in the country to adopt this discriminatory practice, such that other cities around the country actually modeled their redlining practice after what was being done in Baltimore. So if we look at Baltimore today, really, what we see is that even 5 miles makes a world of difference for health outcomes. If we look at a community that's in the northern part of the city, the Roland Park or Poplar Hill community, where around 83% of the residents are white people, there's for us a relatively high median household income of around $105,000. There's a very low unemployment rate, a essentially non-existent homicide rate, pretty high life expectancy that really rivals countries around the world like Japan that enjoy a much greater life expectancy than we do here in general in the US, and a pretty low death rate from heart disease in that community as well. Whereas if you look at the Madison or East End community, 90% of the residents are Black or African American, with about a quarter of the median household income of the Roland Park community, a more than 10 times greater unemployment rate, a high homicide rate, and a 15-year lower life expectancy in this community as compared to Roland Park, and also a 3 times greater death rate from heart disease. And you'll recall that this is the same area that had been redlined now, again, almost 100 years ago. And so certainly a key issue that was patterned by discriminatory practices like redlining and continue to be patterned by racial residential segregation in many cities across the country is this issue of being able to access affordable housing. We have done some work looking at this issue of housing insecurity and its relationship to kidney disease. And this is with my mentee and colleague, Dr. Tessa Novick, where we again looked at data from the Handel study and examined this question of are you able to afford a home suitable for you and your family, and found that in this study that around a third of the participants really reported no, that they weren't able to afford such a home, really indicating that they were experiencing housing insecurity. When we then followed that same sort of participant group over about 3.5 years of follow-up, looking for various adverse kidney outcomes, the main finding that we had that was statistically significant, quite so, was that these individuals were at increased risk for developing albuminuria, so new loss of protein in the urine. They were 3 times more likely to develop albuminuria than people who did not have housing insecurity. Really, and then and I'm sure most of you know, this can be sort of one of the earliest sort of indications of chronic kidney disease. In a separate sort of analysis, but using the same cohort, we sort of zoomed in then on people who already had chronic kidney disease and looking at around 350 Handel study participants, and found that again, more than a third of them in this case were experiencing housing insecurity or housing instability. In this case, when we looked at applying questions like being able to afford a suitable home and also whether or not they were having difficulties making rent or mortgage payments. And interestingly, for those of us thinking about healthcare utilization and sort of postponement of medical care, we found that about a quarter of this patient population had reported, or of this participant population reported having postponed their medical care when they felt like they otherwise needed to seek out medical care, and that housing instability was an independent predictor of postponing needed medical care. Another challenge that has been patterned by practices like redlining is this issue of neighborhood food availability. As Dr. Xu said, this has been a focus of a lot of my work, and one that I'll kind of share a bit with you all about. What we see, and this is a study from Baltimore, what we see is that when we look at this is data where a team went around to all of the food outlets in Baltimore City and Baltimore County and assessed the presence of various healthy foods. So things like fruits, vegetables, whole grains, low-fat dairy foods. Essentially what they found was that there was a greater prevalence of healthy foods, sort of indicated by the size of the green circles, in those communities where the residents were predominantly white, so the gray shaded areas, as compared to those communities where the residents were predominantly Black individuals. And so really, kind of highlighting that there is more healthy food available in predominantly white communities, as well as predominantly higher income communities as well. Another key issue is that many of these same communities face is the issue of food insecurity, where one definition is that it is a lack of consistent access to enough food for an active, healthy life. And what we tend to see in the US is that non-Hispanic, Black, and Hispanic individuals have a greater burden of food insecurity, as you can see by these orange and blue lines here. And that food insecurity tends to spike during times of economic downturn, such as during the Great Recession. And we have seen a similar thing in the setting of the pandemic, where this was kind of a prediction of what was going to be observed in 2020 as compared to 2018. And you can see some of these, the top 4 states, where states like Mississippi had almost a 23% rate of food insecurity. So meaning that almost a quarter of households did not have enough food. We have looked at this issue of food insecurity in the kidney disease setting. This is work with another one of your colleagues, Dr. Tanushree Banerjee, who is here, where we examined a population of people in the National Health and Nutrition Examination Survey, or NHANES survey, and looked at people already with chronic kidney disease, and found that for people with CKD, if they also were experiencing food insecurity, their risk of progressing to kidney failure was greater than those who were food secure. And I think in our case, importantly, when we went on to adjust or account for various factors associated with food insecurity or kidney disease itself, when we found that accounting for various nutritional factors, that it, at least statistically, helped to explain this association between food insecurity and CKD, it really led us to think that perhaps if there was a way to intervene on the diets of these individuals, that we might be able to actually lower their risk of progression to kidney failure. And so this came at a time when we were doing other work, really trying to understand various dietary patterns and their role in determining who would develop kidney disease in the first place, as well as whose CKD might progress to kidney failure. And essentially what we were finding was that dietary patterns like the dietary approaches to stop hypertension dietary pattern, or the DASH dietary pattern, which is rich in fruits, vegetables, whole grains, and low-fat dairy foods, and those dietary patterns that present less acid for the kidneys to handle. So sort of low dietary acid load, which is going to primarily, again, be fruits and vegetables, or more plant-based foods, that these were, these had a protective association, if you will, with in terms of adverse kidney outcomes. And but we knew that in order to support individuals who were at risk for developing kidney failure in following this sort of healthy way of eating, that there would be significant challenges. And so I spoke at the beginning about the importance of centering the margins. My work has really, a big focus of my work has been around centering marginalized Black individuals with kidney disease risk, really to see if we can determine ways to mitigate this risk. And in this work, it's been important to kind of elevate the voices of these individuals, to try to, one, to understand their perspective, but also to identify what they think could be done to sort of improve these outcomes. And so some of this work started off with some years ago now, we conducted a qualitative study, a focus group study, where we recruited low-income Black Americans who had a first-degree family member with kidney failure. So first-degree family member who was being treated with dialysis. And we asked them about, well, what do you think would need to happen, or what do you think the important barriers would be to consider if you personally wanted to make changes to your way of eating that might reduce your chances of going on and developing kidney failure as your family member did? And some of the things that they highlighted included, and these won't surprise you all, I don't think, but that healthy foods are expensive and unavailable in certain neighborhoods. One participant said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. So really kind of highlighting some of these key barriers. They also mentioned that unhealthy foods are more convenient to prepare or to access, and that unhealthy dietary practices had been a lifelong habit for them that they thought might be really challenging to break. And a separate qualitative study, we applied this this sort of qualitative research discipline called photo voice. And I have a few of you in the room here. Anyone ever heard of photo voice besides the ones in nephrology that heard me talk about it yesterday? Okay, so you can have credit. So photo voice is this participatory research approach wherein the participants are actually trained to use cameras to photograph something in their environment. As a means of kind of elevating the voices of those individuals, and also as providing a sort of platform for sort of sharing those experiences. And in our case, we included a group of Black adults who are residents in Baltimore City, and have all of them have hypertension. Many of them also have chronic kidney disease. And we provided them with these cameras, and what they would do is then develop the pictures. We gave them little printers to print out their pictures, and then they would come together in these small groups to discuss what was being seen in the photos. And what I'll share with you are a few of the sort of favorite pictures that the participants picked out that they wanted to share really with others more broadly. One of them took this photograph of this building here that's on the left, and they said, "This vacant building, now people start sitting and drinking in front of it. This is an eyesore. People leave trash, which attracts rats. This building could be turned into an Aldi's." That's a grocery chain on the East Coast. Discriminatory practices against Blacks don't allow them to buy lots and buildings. It's not affordable to a lot of people, so they give up. People want to do good, but don't have the money. We can have liquor stores, but not a market. And so they really highlighted what they were seeing, when they saw this vacant building. Now, importantly, what we've learned through our work, and others have documented well, is that many of these same communities that are socially marginalized also have many community assets, much that in many cases that they've developed out of a need, really to sort of do something given the setting that they're living in. And so this participant, Mr. Davis, shared that he actually had developed a garden at his home where he was growing food that he would consume himself, but was also sharing with his broader community. He said, I tried something I saw out at a store at home. It saved money and it was good. It's complicated to try shopping. People with cars can get around. People in the neighborhood have no access. I try to help when I can. Concerns about crime and safety. If it was easier to get stuff, crime would decrease. And so he had really developed an approach to support his community. And so with these sort of findings in mind, we developed and recently completed a clinical trial called the 5+ Nuts and Beans for Kidneys trial, which was a 12-month, 2-phase, community-based randomized trial for 150 Black Americans that was aimed at addressing some of these real-world obstacles that I've spoken with you about today that exist when it comes to healthy eating for many Black Americans. Our hypothesis was that delivery of nutritional advice to adopt a DASH-like dietary pattern plus $30 a week worth of potassium-rich foods would ultimately lead to a 20% greater reduction in urinary albumin excretion, and also improvements in blood pressure when compared to the provision of a grocery gift card without nutritional advice. And so the findings were, these initial 4-month findings were presented as a high impact clinical trial at our American Society of Nephrology Kidney Week meeting, and the manuscript is forthcoming, but I'll share with you all sort of some of the key findings. This was our study protocol. So we had 2 arms to the study, as I mentioned. So in the so for the upper portion here, the self-directed group, the S- group, as we referred to them, they received this gift card and they would shop on their own with that gift card. They received just a brief sort of brochure and a little bit of information from our study coach at randomization in the study in that first 4 months of the study. But then in the second phase, they didn't receive the grocery gift card, nor did they receive any coaching from the study coach. Whereas in the dietitian directed coaching diet group, or the C- group, in the first 4 months, they received $30 per week worth of these 5+ foods that were delivered to their home. And they also received brief weekly calls with our study coach. And during those calls, orders for their food were placed, as well as they were coached around how to incorporate these foods into their way of eating. And in the second phase, they did not receive the weekly food delivery, but they continued to have periodic telephone calls with the coach. And so I'll share with you the 4-month results, which was the primary endpoint for our trial. So importantly, ours was a community-based participatory research study where we had many community partners, including our grocer partner, ShopRite. So just some key elements of the intervention group. So we were encouraging them or targeting that they would take in 5 servings of fruits and vegetables plus nuts and beans per day. And in their weekly orders, we were ordering for them 17,000 milligrams of potassium, really trying to encourage their following a DASH-like dietary pattern, which is 4.7 grams per day or 4,700 milligrams per day of potassium intake. And we were, you can see on the left-hand side, some examples of some of the foods that they could select from. So we gave them a choice of 60 different foods, and again, targeting both that potassium amount, but also sticking under or right around $30 per week worth of these foods that were, again, coming from our grocer partner. And so I'll share with you just the key outcomes from this study. Sorry, I had a little bit of a PC to Mac issue here, but when we looked at 12 months and we looked at within the coaching DASH group, what we saw was that there was a significant decline in urinary albumin excretion by about 29% reduction in urinary albumin excretion compared to the baseline for that same group. There was also a statistically significant decline, although modest, in diastolic blood pressure, as well as an increase in urinary potassium excretion, indicating which we tend to see when people make dietary changes of this kind. When we looked, though, in comparing the coaching DASH group to the self-directed DASH group, we did not find a statistically significant difference between the groups, although there certainly was a suggestion that the coaching DASH group had a greater improvement in their urine albumin to creatinine ratio. But we did find that the coaching DASH group had greater potassium intake, as well as actually greater fruit and vegetable intake on a daily basis when compared to the shopping DASH group. We had some pre-specified subgroups that we looked at and found that for those individuals who were losing at least 300 milligrams per gram of albumin via the albumin to creatinine ratio, that they actually had a quite robust reduction in their urine ACR if they were in the coaching DASH group of 73% reduction, and there was a statistically significant difference between them and the shopping DASH group in that analysis. We also found a suggestion of a greater impact among those of the intervention among people with diabetes as well. So we were left as a sort of a conclusion from this study that coaching to follow a DASH-like dietary pattern plus healthy food provision led to significant within-group improvements in diet quality and albuminuria, and that coaching was superior to a food subsidy by itself for improvements in diet quality overall, and also albuminuria lowering among people who had this high albuminuria or very high albuminuria. And for the first 25 participants who had completed the trial, we actually did some interviews of them to sort of see what their views were of the trial, and really highlighted some things that they viewed as being facilitators of following this healthy way of eating, including many of them talked about the process of dietary tracking, which was also a part of that coaching DASH group, where they would sort of document what they were eating, and that seemed to help a number of them. They also highlighted that things like getting support from their family members for following this healthy way of eating was really, really helpful in it as well. Some themes that were barriers to adopting this healthy style of eating included certainly the pandemic, because we conducted this trial very square in the middle of the pandemic, and as well as stress. So the stress here that was highlighted by one of the participants was really stress around whether they were going to have enough money to get the food that they otherwise wanted to consume. consume. And so these were some of the findings. So I want to highlight that in work around kidney health equity in particular, and I think health equity more broadly, that advocacy for policy changes is really key. And I've shared with you, as you probably noted, a number of sort of social drivers of kidney health inequity that are really shaped by policies. And so it becomes really important for people conducting research in this space to be advocates as well for these sort of policy changes. And so with that Photo Voice project that I mentioned for you all, we have actually used that as a means to advocate for Baltimore health policy changes. We developed that. We had an artist actually develop this small little poster that we can actually hand out to people that actually summarizes some of the key findings from that study. Which included that the participants really saw this as a social justice issue, that the fact that there was not, in their view, equitable access to these healthy foods in their community. And they themselves pointed to various policies, the sort of tax base, the kind of what the role of elected officials and so forth that they thought would be beneficial for addressing these issues. And we've used this, we've actually several months ago held a symposium with policymakers to really share with them these findings. Those of you certainly in nephrology, but in other fields, will know that may know that kidney health and U.S. healthcare policy are really inextricably linked. Now, we recently celebrated 50 years of the recommendation for the Medicare entitlement for people with end-stage kidney disease. Many of you may know that was sort of spearheaded and supported via a very dramatic congressional testimony that included a hemodialysis patient that was dialyzed on the floor of Congress. And not long after, President Nixon signed into law the end-stage kidney disease program that essentially covers it provides Medicare for anyone who has developed kidney failure, regardless of their age. So even children are eligible for Medicare if they develop kidney failure. Prior to this legislation, there was this, as was referred to by this Time magazine cover, as there was this God committee that would determine who was contributing enough to society or expected to contribute enough to society to warrant them getting this scarce resource of dialysis. And so we've certainly moved past this, but certainly have a lot of opportunity in the policy space. With working with really wonderful colleagues in this area, we've tried to, in particular, advocate through our various opinion pieces, perspective pieces, to try to call attention to some of these inequities and think about what policy levers there are to address them, including thinking about, for example, whether we should be providing nationally, whether we should have a program for people who are experiencing homelessness to actually receive dialysis. And so this is sort of ongoing work in the advocacy space. So really, to summarize our time together, disparities in chronic kidney disease are profound and they have significant societal impacts. The root causes of disparities in CKD include limited access to high quality healthcare, discrimination, as well as the downstream effects of residential segregation. And achieving kidney health equity, and I would argue health equity more broadly, will require a commitment to centering the margins by designing interventions and advancing policies that draw upon the strengths and address the needs of historically marginalized communities. And so I want to thank the participants of the studies that I presented, my colleagues, including at our CKD surveillance team, many of whom are here at UCSF, as well as my colleagues at the Welsh Center in our division, and in particular, thank my colleagues at the Center for Health Equity at Johns Hopkins. And I hope there's time for questions. Thank you.
Thank you. That was terrific and inspiring. I didn't see any cost effectiveness work. I wonder, because the federal government does pick up the cost of failure here, that someone ends up on dialysis, You could argue there's a little bit more of a kind of closed circle. If we spend money on X, we'll save money on Y. Have we done any of those kinds of studies to demonstrate that there's value here?
Yeah. So thanks for that. So I personally have not done as much in the cost effectiveness space, but there are scholars in nephrology, who have looked at that sort of thing, like where are so I can tell you this is a little outside of nephrology, but we know, for example, that benefits around food access. So like the supplemental nutrition assistance program. So we know that people who, compared to people who are eligible for that benefit, but don't receive it, those who do receive the SNAP benefit have lower hospitalization rates, right? So that, again, sort of getting into the dollars. And so many health systems around the country have looked to data like that and said, hey, we can invest in making sure that our population that we're serving has access to food because we know, well, one of the reasons, I'm sure altruism is a part of it, but also because we know that's going to drive down costs. So certainly we need more of that in kidney disease.
Great. Questions? Have questions? While we're waiting, why is high potassium good? Is it just because it's low sodium, or it's because something good about high potassium? Speaking to as a completely naive non-nephrologist.
Thanks. So high potassium is good for several reasons. So one of the things, a high potassium sort of dietary pattern is good for several reasons. One, you all may know that it does certainly down regulates the release of certain hormones like angiotensin 2 and aldosterone, which can actually raise blood pressure. We know that those hormones also have an impact on, for example, promoting fibrosis in the kidney. We also know that the high potassium diets actually they reduce the amount of kind of acid that the kidneys have to handle, so the amount of acid in the tissues of the kidney, which that type of acid actually is injurious to the kidneys as well, and causes complement activation and sort of other factors that can injure the kidney. So that's some of the ways that that it's good. Thanks.
Leshmi, any questions online? Nothing? Anything out there? Yeah, go ahead, Chief. Let me grab you.
Oh, thank you, Deirdre. That was great. Some of the studies about lack of awareness, I think, based on work by Delphine and others, has to do with the way it's asked.
Yeah, absolutely.
Right?
Yeah.
And do you think there's also differences within different subgroups about understanding of certain words, injury versus disease versus, would that be also a factor which complicates our interpretation of the awareness issue? And why, despite, raising awareness, people see kidney doctors and claim they don't know they have kidney disease, which is on the face of it a little suspicious, right? It's not really right.
Yeah, so thanks for that. Maybe I'll repeat the sort of question. So yeah, really about this issue of awareness. And I did share that sort of 9 out of 10 number has been challenged by people like Dr. Tuo, as you mentioned. So in studies, really, because a lot of those estimates come from large data sort of sources, large studies like NHANES, like the National Health and Nutrition Examination Survey, which asks the question that is meant in NHANES is, has a doctor or other health professional ever told you that you had weak or failing kidneys? And that's usually not the way we communicate in nephrology clinic. But I think you raise an important point, Chi, in that it's, I think that part of the challenge is the way we communicate the way we communicate kidney disease to people. I have had seen patients where we've had a visit and then, I'll hear later that they didn't realize they were seeing a kidney doctor. So I've in more recent years have certainly shifted to doing a, hi, welcome to nephrology clinic. We are kidney doctors. You've been referred here because of your you have a problem with your kidneys, right? So really to sort of reframe and hopefully use more accessible language. But I think that's an area that we need to do continued work in. Yeah.
Any last ones? I guess I'll ask the last one is I found that VI study very interesting.
Oh.
I can't remember seeing a study where patients from minority communities were more likely to see specialists than Is that generalizable outside the VA? And do you have hypotheses about why that happened in the VA?
Yeah, so having spent some of my training in the VA, I think, in a VA in St. Louis, I can say that certainly there's the VA, as I'm sure you know, has was earlier adoption of things like EHR based kind of decision support tools that I think might be used by a particular number of primary care clinicians that might point them to a need to refer people. One thing to know is that because Black individuals as well as Hispanic people may have some other findings that may sort of trigger to a clinician that they need to refer a patient, things like albuminuria or sort of proteinuria, that may be why they may look at that person and say, oh, we need to refer you. You've got these indications for referral. And I think in a system where everyone has access to the same kind of sort of equal access to specialty care, that there may be removed those types of barriers that otherwise clinicians may be thinking through if they're thinking about referring a patient, right? So if they, found that they have those indications, they'll go ahead and refer. Yeah.
Makes sense. Okay, our time is up. Thank you, Deidre. Terrific talk. Thank you for your visit. Really appreciate it.